group of lymph nodes based on the location in relationship to the cava. They are further classified into pre-caval, lateral caval, and the retrocaval. The left side of the lymph nodes are just in they're just the left parietic region. That's normally what we call as a parietic lymph nodes. No, so this is left side of the abdominal aorta. The right side nomenclature is in relationship to the that of the inferior vena cava, whether it's located anterior to that or lateral to that or posterior to that. So this lateral aortic group of lymph nodes, from where and all it will drain the efferents from. It drains efferents from the pelvis, that is the common iliac group of nodes. It drains into the lateral aortic group of lymph node. Then the other important organs are the adrenal. Then the next one is the kidney, perirenal fat capsule, and the abdominal part of the ureter. So these drains into the lateral aortic group of the lymph nodes. And the next one is the gonads, whether it's the testis or the ovaries, and the ovaries and the adjacent portion of the fallopian tube, it drains into the lateral aortic group of the lymph nodes, and as well as all the structure which are supplied by the posterior and the lateral paired branches of the abdominal aorta, including the deep parietal layer, which is the muscles and the fascia. They are also drain into the lateral aortic group of the lymph nodes. So this forms a main lymph node for the urogenital system. If you take the urogenital system, the main lymph node is the lateral aortic group of the lymph nodes, and it has multiple connections to the pre and post aortic lymph nodes, post aortic group of the lymph nodes. And from here, there are two important trunks it drains in two important trunks. One is the right trunk and another is the left lumbar trunks. So right and left lumbar trunks, it give rise to that, and it joins with the cisterna chyli. So we know that pre-aortic group of lymph nodes ends in the intestinal trunk and it opens into cisterna chyli. The lateral aortic group of lymph nodes are further ends in the lumbar trunks, right and left lumbar trunks, and that opens into the cisterna chyli. So in this example, if you see, there are multiple enlarged lymph nodes. This is the aortic bifurcation, just at the aortic bifurcation level, and this is the inferior vena cava. So the right lateral group of the lymph nodes are based on its relationship to that of the inferior vena cava. So when the node is situated anteriorly to the inferior vena cava, they are called the precaval, and when it's situated laterally, it is called as lateral caval, and when the lymph nodes are situated posteriorly, it is called as the retrocaval. This is the aortocaval lymph nodes, or the lymph nodes which are seen in between these two groups. And when you see the lymph node which is along the left side of the aorta, they are the left lateral aortic group of the lymph nodes. So this is the coronal image which demonstrates that the multiple enlarged lymph nodes along the left lateral group of left lateral aortic group of lymph nodes are enlarged. The coronal section demonstrates that findings. So the next comes the post aortic nodes. This post aortic node, as such, it does not possess any specific lymphatic territory, and it's functionally linked to the lateral aortic group of nodes, and it shares the same drainage area. So we have seen the pre-aortic, that is the peri-aortic lymphatic region. We have seen the four groups, out of which one is the pre-aortic, then the lateral aortic, and then the post-aortic. And lateral aortic, again, the pre-aortic group of lymph nodes which drain the digestive portions, and the lateral aortic group of lymph nodes which drains the urogenital system. So when you classify the drainage as such, you can classify something like three levels: level 1, 2, and 3, depending upon the location. D12, L1, and L3 vertebra. The D12 is the superior mesenteric, the cilia group of the lymph nodes, and L1 is the superior mesenteric, and L3 is the inferior mesenteric. If it is level, the sublevels 1A, the A corresponds to the intraperitoneal organs, the median and the intraperitoneal. They correspond to the lymph node location which drains the intraperitoneal organs. Similarly, 1B is also seen at that level, which drains the adrenal and the upper pole of the kidneys, and 2B are the kidneys, ovaries, and testes, and 3A are the ovaries and the testes. So that corresponds to the lateral group of lymph nodes, and which drains the retroperitoneal organs and structures. So this is just on how we can classify the levels of the lymph nodes. So coming to the pelvic organs as such, the lymphatic drainage of the female reproductive system, again, if you see, we know that the ovaries drains into the right and left lumbar lymph nodes, and similarly, the fallopian tubes can drain into lumbar, or it can drain into the internal iliac lymph nodes. Uterus, if you take the fundus, it's further it is divided into three categories: fundus, body, and the cervix. and the fundus portion is drains into the lumbar and superficial inguinal group of the lymph nodes. The body drains into the external iliac, and the cervix drains into the internal iliac and the sacral group of the lymph nodes. And the vagina, they are divided into four. One is the superior, middle, and inferior, and the external orifice, which drains into the superior and middle drains in the iliac group of lymph nodes, while the inferior portion, again iliac group of lymph nodes, the sacral and the common iliac lymph nodes. The external orifice drains into the superficial inguinal lymph nodes. If you take the vulva, it's again drains into the superficial and the deep inguinal group of lymph nodes. In the case of the male reproductive system, the testis drains into the lumbar group of the lymph nodes. The ductus deferens, ejaculatory ducts, seminal vesicles, prostate glands, and bulbourethral glands predominantly drains into the internal and the external iliac lymph nodes. The penis, they are classifying the divided into skin and the glans penis portion. The skin drains into the superficial inguinal group of lymph nodes, while the glans penis and corpora drains into the superficial, deep, and the inguinal group of lymph nodes, as well as the external iliac nodes. So scrotum drains into the superficial inguinal group of lymph nodes. So here all these nodes are draining into the iliac group of lymph nodes or the inguinal group of the lymph nodes. We'll just see that also. So if you take the rest of the pelvic organ, which is the left out of the ureter further is classified into superior and middle and inferior. We know that abdominal part of the ureter drains into the lumbar group of the lymph nodes. The middle part of the ureter drains into the common iliac nodes, and the inferior part of the ureter drains into the external iliac nodes. Urinary bladder, they drain into the internal and external iliac nodes. Particularly the internal iliac node drains the fundus and the neck region. In the case of the urethra, the female, it opens into the internal iliac nodes, and the male, it opens into the males further classified into proximal or distal. The proximal group of lymph nodes drains into the internal iliac nodes, while the distal group drains into the inguinal group of the lymph nodes. So when you take the lymph nodes as such, the common iliac nodes, the common iliac group of lymph nodes, again they are classified into three. One is the medial, middle, or the lateral. So the medial group of the lymph nodes are those nodes which are located in the central triangular area between the common iliac arteries and extending till the bifurcation bifurcation into the origin of the external and internal iliac arteries. That's the medial group of the lymph nodes. While the middle group of the lymph nodes are those lymph nodes which are seen in the region of the lumbosacral fossa. The lumbosacral fossa is bounded by the sacral promontory posteriorly, by the vertebra medially, and the psoas muscle laterally, and the iliac vessels anteriorly. So when you are appreciating a lymph node at that level, that is called as the middle group of the common iliac lymph nodes. And the lateral group of the lymph nodes are those lymph nodes which are seen lateral to the common iliac artery and extend lower as the lateral external lymph nodal chains. So if you see in this example, this is just seen below the bifurcation in the triangular area between the common iliac arteries. So this forms the medial group of the lymph nodes. And this is the lumbosacral fossa, where it is bounded by the laterally by the psoas, medially by the vertebra, the posteriorly by the promontory, and anteriorly by the iliac vessels. So this comes under the middle group of the common iliac lymph node. And when it comes to the lateral aspect, when the lymph nodes, if you're appreciating a lymph node lateral to the vessels, it is the lateral group of the lymph nodes. Similarly, the external iliac group, again, they are classified into three. One is medial, middle, and the lateral. The medial group of the lymph nodes are usually seen medial and posterior to the external iliac vein. So some of these lymph nodes are called as the operator nodes because as it accompanies the operator vessels. And the middle group of the lymph nodes are seen, which is seen between the external iliac artery and the vein, while the lateral group of the lymph nodes are those lymph nodes which are seen along and lateral to that of the external iliac artery. So in this example, if you see this is the middle group of the lymph node which is seen between the external iliac artery and the external iliac vein, and this is the lymph node which is seen medial and posterior to the external iliac vein. So this is the medial group of the external iliac lymph nodes, and this is the operator artery, which is a branch of the anterior division of the internal iliac artery. So sometimes they may call it as the operator group of lymph nodes. And laterally, if you see the lymph nodes lateral to that of the external iliac group, they are called as they comes under the lateral sets of the external iliac nodes. The next comes the internal iliac nodes. Sometimes they call it, the people used to call it as hypogastric nodes. These are the several group of the lymph nodes which are located along the visceral branches of the internal iliac artery, and they are identified based on the branches of the internal iliac vessels, namely uterine artery or the inferior and superior gluteal artery or internal parental arteries. So there are three sets are there. One is the anterior nodes, which are located anterior to the internal iliac vessels at the origin of the umbilical and operator arteries. Or the second set of lymph nodes are the lateral sacral group of the lymph nodes, which lies anterior to the first two sacral foramina along the lateral sacral arteries. So these are the lateral sacral nodes which lies anterior to the first two sacral foramina along the lateral sacral arteries. And then the presacral groups are also included in the internal iliac nodes. So if you see in this example, there are multiple lymph nodes along the internal iliac arteries. And this is the lymph node what we are discussing. That's a lateral sacral group which is seen anterior to that of the first two sacral foramina along the lateral sacral arteries. So lateral sacral group of the lymph nodes. So when it comes to the inguinal group of the lymph nodes, they are further again classified into two. One is the superficial group of the superficial inguinal group of lymph node, and another is the deep inguinal group of the lymph nodes. So the superficial group of the lymph nodes are those which accompany the superficial femoral and the saphenous veins, while the deep group of the lymph nodes are those which is seen within the femoral sheath, mediating to that other common femoral vein. So the structure which differentiates the deep group of the inguinal lymph nodes from the external iliac lymph node is the level is the origin of the inferior epigastric and the iliac circumflex vessels. So when it's seen deep to that, that is the external iliac group. When it's seen superficial to that, that is called as the deep group of the inguinal lymph nodes. So in this case, if you see, there are multiple lymph nodes are seen, which is seen adjacent to this is the great saphenous vein, and this is the superficial femoral vein. So this falls under the superficial inguinal group of the lymph nodes. And this is the lymph node which is located just median to the common femoral vein within the femoral sheath. That is the deep group of the inguinal lymph nodes. And if you see here, you can appreciate the origin of the inferior epigastric artery, and the lymph nodes are seen deep to that. So this falls under the external iliac group of the lymph nodes. So other than this, there are few lymph nodes are also seen along the perivisceral region. So if you see here, the prevesical group of lymph nodes and the lymph node which is seen along the lateral to that of the bladder, that is a lateral vesical group, then paravaginal group of lymph nodes, parauterine group of the lymph nodes, and the one that the mark one suggests it's a lymph node along the superior gluteal arteries, and there are few lymph nodes are seen adjacent to the rectum. They are called as the perirectal group of the lymph nodes. So these are some of the perivisceral groups of the lymph nodes in the pelvic region. So the next comes to the retrocrural nodes. So the retrocrural space is a space which connects the posterior mediastinum to the retroperitoneum, and which act as a conduit for the communication of the disease process. And this retrocrural space contains the aorta, thoracic duct, azygos vein, as well as the retrocrural group of these lymph nodes. And this retrocrural group of the lymph nodes drains the diaphragm, posterior mediastinum, and upper lumbar region. So normally when you are viewing the abdomen CT, normally we can see this retrocrural lymph nodes, and these are considered to be abnormal when it is enlarged and when they exceed the diameter more than 6 millimeter. So this is an example for the retrocrural lymph nodes, which is seen posterior to that of the crura, and when it's more than 6 millimeter, it is considered to be abnormal. So when you so these are some of the stations we are seeing. So we are seeing the periatic group of the lymph nodes, which is a main draining area. So the periatic group, again, the pre and both lateral aortic, though there's a classification called post aortic, it is not having any specific lymphatic drainage. The pre-aortic group of the lymph nodes, which drains the digestive portions, and the lateral group of the lymph nodes, which drains the common iliac nodes, as well as the urogenital system. Mostly it drains the urogenital system. And these again, they converted into trunks, the right and left lumbar trunk, as well as the intestinal trunk. All these open into the cisterna chyli. Okay. So when you identify a lymph node, the next step is we have to identify whether it's a normal lymph node or the abnormal lymph node. So as we discussed earlier, the size is the widely accepted criteria. And in most of the areas, when the lymph nodes are more than 10 mm short axis, is then considered to be it's enlarged, other than the specific region like the retrocrural or the perirectal regions. And when it comes to the shape, if it is an oval shape, it's normal. When you take the round shape or associated with the eccentric cortical hypertrophy, then you have to consider that lymph node as abnormal. Whether the hilum is preserved or it's lost, that's a very important one. And see the margins. When the margins are smooth, then it goes in favor of normal. When the margins are, whether it's a vanishing border sign or the flare sign or the saggy margin sign, then it suggests it's an abnormal lymph node. Then you have to look for the attenuation. In the case of the CT and MR, you have to look for the attenuation and signal intensity in the plain scan, whether it's homogeneous or heterogeneous appearance. And when it's heterogeneous, again, it suggests it's a pathological node. And coming to the enhancement part, after giving the contrast, whether it's showing a homogeneous enhancement or it's showing the heterogeneous enhancement. If it is homogeneous enhancement, it is normal, and no, it's, in the sense whether it's showing homogeneous enhancement or the heterogeneous enhancement. If it is heterogeneous enhancement, then you can just narrow down the differential diagnosis. As we know, in the case of the tuberculosis, we can see the areas of necrosis. You can see in the metastasis from squamous cell carcinoma, you can see the areas of necrosis. So that help us to narrow down the differential diagnosis. So when you find that as an abnormal one, then the next comes the question whether it's a malignant node or it's a benign enlarged node. So that portion we'll see when we are discussing about the pathology. And we should also should know some of the mimickers of the lymph nodes in the abdomen, particularly for example, this unopacified bowel loops, as well as the prominent normal vascular structure like gonadal veins and iliac cells sometimes mimic the lymph nodes. And vascular anomalies, particularly the left-sided IVC or the duplicated IVC and the varices resulting from the portal hypertension may mimic a lymph node. The papillary process of the caudate lobe or sometimes the bulbous scallop diaphragmatic crest, they can also sometimes represent, they may resemble a lymph nodes. And other mimickers can be a normal ovarian tissue or the accessory spleen. So you have to evaluate properly before term it as a lymph node. So this is an example where the axial section, if you see the IVC is seeing the aorta is in, and the left lateral aortic group of lymph node, it may appear like a left lateral group of enlarged lymph node, but if you see carefully, then you can see the continuity of the structures. So this is turned out to be a duplicated inferior vena cava, where it at the level of the renal vein level, it just crosses and joins the IVC. So you should know the mimickers of the lymph node as well. So again, why we need the lymph node imaging? Because of the increase in the advancement in the both software and hardware part of the MDCT and MRI, we are detecting more and more lymph nodes now. And with the emergence of the functional imaging technique, we are able to pick up the metastasis even in the small group of the lymph node. So we should be able to know the stations so that we can stage the disease, as well as we can search for the pathology in a particular organ if you know the lymph node stations. So with this, we come to the end of this session. So I hope you learned something today. So if the time permits, we can assess that by going to the question polls. Thank you. Shall we move to the polls, or?
I think we can have around 5 questions.
5 questions. Okay, Sudarshan, then you can just proceed with the first 5 questions. Not a problem.
Okay, sir. I'm starting the polls. Sir, the poll is live, sir.
Okay. The first 5 questions, no?
Yes, sir.
Okay, these are very easy questions, but this just this question, the things whatever we have discussed now. The first question is typically a hilum of lymph node contains one afferent lymphatic vessel, one efferent lymphatic vessels, numerous afferent vessels, or numerous efferent vessels. So that's why you can just let me know once the poll is over.
Yes, sir. I'm ending the polls.
Okay. So the answer is we know that because when we discussed about the lymph node receives multiple afferent lymphatic vessel, but the efferent is only one efferent, and it goes through the hilum and along with the arteries and the vein. So the answer is B, one efferent lymphatic.
Yes, sir. 50% of attendees answered option B, sir.
Okay. Okay, that's one efferent lymphatic vessel.
Yes, sir. Sir, the second question is live, sir.
Okay. So this is another easy question. So lymph contains all except B lymphocytes, T lymphocytes, red blood cells, plasmacytes.
Sir, I am ending the poll now.
So we know that lymph contains the lymphocytes and the plasmacytes, so the RBC won't contain the
Yes, sir.
RBCs.
86% of attendees answer red blood cells.
Good. So the next question is of the lymphatic trunks, which one drains from the urogenous system, whether it's jugular trunks or subclavian trunks, intestinal trunks, lumbar trunks?
Yes, sir, the question is live. Sir, I am ending the poll.
No, we have discussed this one. That's what during discussion part we told the pre-aortic group of the lymph nodes, whether celiac, superior mesenteric, and inferior mesenteric, it ends in the intestinal trunk and it opens into the cisterna chyla. The urogenital system, the main draining is the lumbar group of the lymph nodes, the lateral aortic group of lymph nodes, and they are further. There are two trunks will be there, right and left lumbar trunks that opens into the cisterna chyla. So this answer is D, the lumbar trunks.
Sir, 91% of attendees answer option D.
The fourth one is that the thoracic duct and right lymphatic duct empty the lymph into the inferior vena cava, subclavian veins, inferior vena cava, and the azygos vein.
Sir, I am ending the poll now.
We have discussed this, both the thoracic duct and right lymphatic ducts empty into the subclavian veins. So the thoracic duct is the one which drains major portion of the body. The right lymphatic duct drains the minor portion of the body, that is right half of the face, right side of chest, and right upper limb.
Sir, the fifth poll is live.
So the lymphatic system, two main functions are the endocrine function, neural support, the immunity and fluid balance, fluid production, endocrine function, and removal of fat from the blood, and the inflammatory responses.
Sir, I am ending the poll now.
The first 2-3 slides of during this presentation we just discussed this point. So lymphatic system is main part of the circulatory system, maintains the fluid balance, and it forms an important role in the immune defense mechanisms. So the answer B is correct: immunity and the fluid balance.
79% of attendees answer option B. Sir.
Thank you.
Sir, can I go for question 6?
No, I think we'll just ask.
Sir, can we take a few questions?
Yes, ma'am.
Dr. Venkatesh, that was a wonderful lecture. I think all of us have to go home now and read up in detail and revise whatever you have taught us today. Thank you for that wonderful lecture. Many of the residents have asked this question. So how to measure the short axis diameter? Can you tell us the cutoff of abdominal lymph nodes?
As we discussed, whatever the dimension, whatever the in a sense, whatever the plane, we have to take the shortest dimension. We are not in the axial or sagittal. Whatever the plane, we have to take the shortest dimension as short axis dimension. We have to measure that, and cutoff as such. We are following the 10 mm criteria at most of the places, except in few areas as we discussed in the retrocrural, perirectal, and presacral groups, mesenteric group. The retrocrural and the perirectal 6 mm is the cutoff we are using, and presacral 8 mm is the cutoff we are using, and in the mesenteric more than 6 mm is abnormal.
So the next question is, can you share any chart? Do you have any chart to share these normal dimensions cutoff?
There are few, no, as of now, I'm not having anything like that. Then that means I will just share with the admin groups. They will share in the mail.
Okay. portocaval lymph node comes under which group?
No, the lymph nodes along this portal group, no, this comes under the hepatic group of lymph nodes
Okay.
on the portal veins.
What is the significance of a single right paravertebral lymph node which is necrotic?
Single right paravertebral. What's the significance? We have to see the location now. First, we have to see the location.
Okay, so I think that was a broad question.
Yeah.
Okay. What is the difference between 4A and 7 gastric group of lymph node?
4A and 7. No, that depends upon the relationship to the gastric artery. So if it is seen very at the level of origin of the gastric artery, you are talking about this one, no?
Yes, yes.
Yeah, 1 second. Just so that. Yeah, this one. So when it's close to the origin of the gastric artery, it is 7. What's
Okay.
the 7 and 3A? They meant, I think, 3A.
They asked, okay.
So 3A.
The question was 4A. Okay.
The 3A is the group which is just seen along the distal aspect of the left gastric artery. When it's close to the origin, it is 7.
Okay, sir. Okay. Thanks a lot for your wonderful lecture, sir. I think we'll end your session now.
Okay.
Thank you once again.
Thank you, ma'am. Thank you.
For the next session, we move on to Dr. Sudhir Gokhale's session. Sir is a senior consultant radiologist from Indore, and he has published several papers in national and international journals. Sir, we are very happy to have you today for this lecture for the residents, which is going to be immensely useful, I am very sure, on mesenteric arterial Doppler. And there is an add-on point that his article on abdominal wall sonography in JUM was one of the top 5 most read articles for more than 4 years. So with this short introduction, over to you, sir, for this session on abdominal Doppler with respect to mesenteric vessels and portal system.
Thank you, Dr. Subhashri, and good evening, everybody. So what I'm going to do in the next session is to talk about how do we go about scanning, examining the mesenteric vessels and the portal vein, talk about the anatomy, and talk a little about the technique of examination. So first I'll talk about the mesenteric arteries, and then I'll talk about the portal vein as such. Now we know that the celiac and mesenteric arteries are the ventral branches of aorta. So they are unpaired ventral branches. So they come off the interior aspect of the aorta, and that makes it a little easier for us to examine these vessels when we are approaching the patient's abdomen from the ventral aspect, as we do in our ultrasound examination. So the celiac artery or celiac trunk, as we call it, is the first ventral branch. And then you have the superior mesenteric, and then you have the inferior mesenteric. So basically there are 3 unpaired ventral branches of the aorta which supply the gut, the different parts of the gut and the liver and the digestive organs as such, mainly the celiac trunk. The rest of the 2 mesenteric vessels will supply the rest of the gut. So as far as ultrasound and Doppler examination of these vessels is concerned, patient preparation helps. Patient should be fasting for 6 to 8 hours prior the examination. So that takes care of the gastric residue, which would hamper. It is particularly important if you are planning to do a mesenteric vascular examination to tell the patient not to drink lots of water, because the patients nowadays are primed to come for an ultrasound examination having drunk lots of water. It's not the water that gives us trouble, but it is the air that the patient swallows with water, which creates a lot of artifacts when you are doing a Doppler study. So it is better to tell the patient to come totally fasting. Don't drink lots of water before you come for the examination. Use the standard abdominal probe to begin with. And if the patient is a lean and thin guy or a lean and thin kid, you can switch over to a higher frequency probe as and when it is needed. The aorta is examined first in a longitudinal scan that allows for identification of any aortic pathology, which might have some relevance to the mesenteric circulation. The splanchnic arteries are ventral branches and they're easily seen in sagittal and transverse axial scans. Even on 2D, you can very easily see the all the three ventral branches of the aorta. As we said, celiac trunk is the first large branch. SMA arises just inferior to it, and inferior mesenteric arises from the left anterior aspect of the lower abdominal aorta. Now we use color Doppler to map the flow in the vessels. So it gives you at a glance, it gives you a map. It shows you where the vessel is. It tells you whether the vessel is patent, and it gives you a general idea of the flow in the vessel. And then once we have examined the vessel, we have done a general morphological assessment of the vessel, then we do a pulse wave Doppler sampling to measure velocities, which tell us about the flow in these vessels. It is very important to identify separate origins of celiac trunk and SMA because they are very close together, and we'll see that. Because when you are sampling, when you are putting your pulse wave Doppler sample, it should not be large, otherwise you will have a lot of contamination from one vessel to another, and you need to place your sample correctly in the celiac trunk or SMA because, as I said, their origins are very close to each other. The inferior mesenteric origin is also on the ventral aspect, just a little left to the midline, and it's not very difficult to see the inferior mesenteric artery also. Now, when we talk of Doppler, we realize that these vessels have a distinct flow waveform, which is different from the flow waveform of the aorta. And there is a reason behind it. The celiac trunk, because it supplies the vital organs like liver, shows a lot of diastolic flow. And it has a what we say a pan-diastolic forward flow because it supplies a vital organ which needs to be perfused throughout the cardiac cycle. So celiac trunk will have a large diastolic flow, and that is what we call as a slightly low resistance waveform. As compared to that, the mesenteric arteries have a relatively higher resistance waveform, particularly when you are examining the patient in fasting state. There is not so much of diastolic flow in the mesenteric arteries. So they will show a slightly higher resistance waveforms. And once we do a number of examinations, we get used to seeing these waveforms, and they are called as the Doppler signature of that particular vessel. So we'll see how it looks. So normally we'll start our examination in the midline when the patient is supine. And as you know, the orientation is that the patient's head is on your left and patient's foot end is on your right. That's the normal orientation. So when we are in midline, we'll see the aorta and we'll see the two vessels, the first and second branch coming off the aorta from the ventral aspect. And there even on 2D, you will be able to appreciate that the aorta and these vessels pulsate. they will show normal pulsations even on your 2D grayscale examination. That is normal. If they are not pulsating, then we have to think why they are not pulsating. So that's the normal first thing that we'll do. We'll do a mid-sagittal section to look at the origin of the celiac trunk, look at the origin of the SMA, and that also gives you a fairly good idea of their caliber. This also lets you examine the aorta, and as I said, that aortic disease might have a repercussion in the mesenteric circulation, and therefore it makes sense to have had a good look at the aorta, the aortic wall, if there are large plaques or if there is an aneurysm, if there are any thrombi, if there are any mural thrombus on the aortic wall, because all that is going to have repercussions on the mesenteric circulation. So having done that on your 2D grayscale examination, then only you will switch on the color Doppler. Now, because these vessels are ventral branches, they are coming towards your probe, and therefore the Doppler signal pickup would be fairly good. It will be better in celiac trunk as compared to the SMA, because the celiac trunk is almost parallel to your ultrasound beam. So when the Doppler angle is almost zero, the signal detection is far superior, and therefore it might appear on color that the velocities in celiac trunk are far higher than the velocities in the SMA. And that might not be true. That we'll see when we sample a pulsed wave Doppler sampling to measure the velocities. That's different. But when on a mid-sagittal scan, it is easy to pick up the origins of the celiac trunk and the SMA, and to make sure that although they are very close together, they have separate origins, both these main vessels. Now, celiac trunk, as I said, is the first ventral branch of the aorta. It arises from the ventral aspect of the abdominal aorta just beyond the diaphragmatic hiatus. It is a short artery. It is a short vessel. It has a length of around 1 to 2 centimeters, and immediately after that it divides. It divides into 3 branches. 2 are large branches. The third is a smaller branch. So sometimes it appears as if it bifurcates. So it almost creates what we call as a T sign or a seagull sign. It branches into left gastric artery. That's the smallest branch. It supplies the lesser curvature of stomach. The moment it arises, it starts coursing superiorly and to the left side, the left gastric. And then we have the 2 larger branches, the common hepatic artery, which supplies the liver, the pylorus, the gallbladder, duodenum, and pancreas, and the splenic artery, which supplies the greater curvature of the stomach. As it courses to the left side, it gives out branches to the pancreas, and then it supplies the spleen. Now on ultrasound and on color Doppler, we are not able to see all these tiny branches unless you spend a lot of time searching for them. And that's not the purpose of doing Doppler. The Doppler allows us examination of the major vessels and the flow in the major vessels. So best is to start examining the celiac trunk in a transverse axial section. And as I said, as it comes out, because it is flowing towards our probe, the color Doppler signal pickup is very good. But it is a short vessel. It's not a very big vessel. After about 1.5 to 2 centimeters, it branches off into 3 branches. But mainly because the 2 branches are large, we are able to see these 2 branches. The third branch is lesser branch, and it courses off posteriorly and superiorly the left gastric artery. But we have the celiac trunk going to the right side, and the splenic artery going to the left side. Now, you know that the flow direction is shown by the color. So when you are in transverse section and you are looking at the celiac trunk, you will have the main trunk flowing towards you, and therefore it will be visible in yellow or oranges. And the moment the splenic artery or the hepatic artery curves back, they will start showing color in blue. That is because the direction of flow is away from the probe in these two arteries, and as they branch off and they curve backwards before coursing to the right and left side. That is normal. And then we will sample the flow by using pulse wave Doppler in the celiac trunk